Good morning and welcome to our monthly live broadcast from Mount Sinai Hospital here in New York City. I'm your moderator here, Vishal Kapoor, and I'll be joined by my moderator online, Dr. Atul Kukar, as well. We have another exciting case here from the lab with Dr. Christian and his team in collaboration with vascular surgeons who have been an integral part of our team, both on live cases and off the cases as well. Before we go to the lab, I just wanted to give a gentle reminder to our second annual New York Endovascular Summit, which is scheduled for next week, October 7th and 8th. 2 days of exciting conference where it involves interdisciplinary approach between vascular surgeons, interventional radiologists, and interventional cardiologists who will all join together on this venue here in Midtown Manhattan, where we'll discuss cases of ranging from peripheral arterial disease, venous disease, aortic disease, and more. So we'll be happy for everyone who can join us. They can go to our website, nbyebs.org, register there, and you can have an exciting time. Of course, we'll have our regular scheduled fellows, endovascular fellows course as well, a day before on the 6th, which again, we already have around 80 fellows registered for a good intensive day of training, learning, interacting, and of course, ending on a good note where we get prizes for the interventional fellows, most technically challenging cases. So before any further ado, good morning, PK.
Charles, thank you for that wonderful introduction of the course. We're thrilled today. We have an exciting case, I think, which is going to stand up in terms of complexity to the cases that are going to be presented at our summit. So I just want to go a little bit about our summit before I introduce our team, who all of you know very well. This year it's very different in a lot of different ways because yes, we have an aortic course, yes, we have a fellows course and a venous section. But what we've done is, the peripheral arterial disease non-aortic part of it remains the same. Live cases there are done by Dr. Metzger from Kingsport, Dr. Adams from North Carolina, Dr. Hanau from New Mexico, and Dr. Jihad Mustafa, Fadi Saab, our dear friends from Grand Rapids, as well as Mount Sinai with Ram and myself, you and Karthik. But the exciting part here is that Rob Lookstein and his team is doing 4 venous cases live from Mount Sinai, which are going to be very exemplary in terms of complexity in deep venous stenting, dealing with the decision making that's there. So you're going to have 4 wonderful venous cases that Rob's prepared. And really exciting for me is that Ajit Rao and his team with Dr. McKinsey and of course all the other leadership of vascular surgery has put together this wonderful aortic course, which is for early career as well as advanced as well as fellows, where they're going to have cadaver labs, case presentations, discussions. So I think this course is very exciting because of the fact that we've continued to evolve and add certain nuances that are going to make this better for experience for you. For the physicians of the group, what we call as allied professionals, our very own Beth Oliver and our entire Mount Sinai nursing team is putting together a fantastic nurse tech course. And in conjunction with the New York School of Podiatric Medicine, we're putting together a world-class podiatry course as well. So it's pretty much a one-stop shop for all of you, and I hope that you guys do come. I know a lot of you watch this, so I hope you come either virtually or live. So, to my right is Dr. Raman Sharma, who needs no introduction. He's been with us for a long time. To his right is Dr. Ajit Rao, who's the director of research, as well as a dear colleague here with us at Sinai. And then to his right is Osman Jaffer, our endovascular fellow. We're missing Ray Lascano, who's a little under the weather. Ray, here's a shout out to you. Feel good. And we've got Jen and we've got Liz, our nurses, and Damien outside. So without further ado, let's go to Osman to present the case. And it's quite a complex case today.
Thanks, PK. This is a great case. It's an 83-year-old female, history of hypertension, hyperlipidemia, PAD, PTAs. The last was in August 2017. Then 8060 to the right external, CAD, prior MIs. Her last PCI was in April as well, left carotid endarterectomy. She's coming with left greater than right claudication with Rutherford category 3 symptoms. She was lost to follow-up a little bit after 2017 and then came back to clinic in May. Refused intervention, but then symptoms got worse, and in August we saw her again in clinic and then brought her back to the cath lab, and we'll show you some films. Her medications are as above: aspirin, Brilinta, Atorvastatin, Toprol, Imdur, and Cilastazol, and she's got Doppler pulses bilaterally. So these are just the films. This is the runoff from last time. occluded SFA with reconstitution down in the popliteal area with one vessel runoff down the right leg. Looking at the second picture on the right, the left leg, you can see very similar anatomy on the left side as well. The common femoral with some disease in there, and then one vessel runoff also down that leg. Just wait for this picture to come. You can see down the left leg over there. Again, reconstitution down in the pop with similar anatomy down there with one vessel runoff down there as well. This is her aortic picture, very calcified aorta, as you can see, with a big collateral coming off the aorta right there. We tried her doing this case a few weeks ago. Very, very difficult case. We had a 5 French on the left, a 7 French 5 centimeter bright tip on the right, and essentially tried with multiple 014 wires, Confianza, Stato from both retrograde and antegrade, and then upgraded to 018 system. Still, you can see how far we got with the wire subintimally, almost to that blunt stump, the ostial left internal iliac, but we're not able to cross because of radiation and dye. We decided to bring her back, trying a different approach this time. So despite her therapy and her persistent symptoms, we brought her back today. We're planning for a CTO, again, the left common iliac into the common femoral. We were planning originally radial, very difficult radial. We tried to get left radial access, not much of a pulse on the right. The wire was not passing, so we're going to try, again, bilateral femoral with some CTO re-entry devices today. But we will talk a little bit about some of the radial equipment for interventions from R2P. So again, we'll talk a little bit like we always do about indications, anatomic consideration, task classification, the R2P interventions, and then some of the re-entry devices for endovascular CTO devices, as well as choice of stents for iliac interventions. So obviously for
why don't we wait here? I mean, obviously
yeah.
she's pretty much very, very symptomatic. I just want to go over while we discuss what we're going to do. So what we did was we got right access with a 5 French. I did a quick aortogram. You can see that nothing's really changed from the last image that you saw. I'm not going to waste dye on runoff. Obviously, we know what it is. It's not changed in 3 weeks. And you've got the stump of the what is it called, common femoral. So what we decided to do was, under roadmap guidance, we went ahead and stuck the common femoral. As you can see, I have no arthritis of my hand as Jim McKinsey would say. Went ahead and stuck it with the micropuncture. Then Raman and I put the wire to the external iliac, the circumflex iliac carefully, made sure that we're not perfing anything, and then we advanced the micropuncture sheet in, and then we switched here to check our position, and then we went ahead and switched out, looped the supercore wire. And I think it's important here to understand the equipment. We went with a short 8 French bright tip cordis, which is I think 2 centimeters or 4 centimeters, I don't remember, and we put it into that disease, the common femoral / profunda. And then we took a picture to show you where we are. You can see the bright tip is right there with a very short sheet. And I think, unlike using a 25 centimeter sheet, which is very difficult for you to advance, so on and so forth, I think this is a nice way of doing it. So now we're at this stage right here. And I guess I want to turn it to Ajit to see what is the approach. I just want to give a little logic, because I know Ajit and I discussed this. The idea would be, it was one endo attempt, again, live with the re-entry. If we fail, we convert it to a fem-fem. She has a fem-fem bypass and then goes home. Obviously her left leg is very diseased, so she'll probably need an endarterectomy with the fem-fem, and hopefully that'll help her significant claudication. So that's kind of where we are. I mean, she's bordering on rest pain, as Osman was talking about. So Ajit, I mean, in these kind of cases, is this a similar approach you guys take? What is it that you do?
Yeah. I think,
Just watch this,
for vascular surgery, we always think about the open options, but iliac stents do very well in the long term. So I think trying an endo first approach is good. I would have probably done the same thing. I would have tried to cross it from below. And then if I couldn't, I would have brought the patient back and tried to cross from above. Ideally, we would have done like radial or brachial access.
Ideally, yeah.
And then we would still probably try to snare and treat from below, because the kinds of stents you need potentially use larger sheets, which you can't do from above.
Right.
But yeah, I would have done the same thing.
Yeah, so again, I guess wire-wise, I mean, this is really not much to really discuss, right? I mean, the way I approach this, Ajit, and I don't know, Vishal, whether you do it differently, Raman, I wouldn't do this, yeah. It's just, kind of make the pathway up. We know we've already dissected. We have a target point. We just want to, don't want to get outside the calcified line, which is very important. I think it's very important to see that. So Raman's obviously going to just advance this angle glide wire, right? Just going to push it up. Oops.
I think we're in a different.
Yeah, I think the most important takeaway point from this case would be
okay.
Right, to have a vascular surgeon in your room, especially with doing these complex cases. Of course, everybody does a heart team, vascular team approach, multidisciplinary, but in this case, it's like PK rightly said, having a vascular surgeon with you, with an extra eyes and an extra hands in this complex occlusive aortoiliac disease is very essential. So I think that's a great option that PK has taken up. In regards to the intervention part, I think bilateral femoral will be a great option in this case. The radial pulse, like Osman said, is not the best in the world. So getting access from the top is just a bit harder. And you do have a good knob. So I think going femoral, or even sometimes if you want a little bit more room, you can actually do a SFA stick and just do manual compression if you want to. But in this case,
I think here, like Raman and I and Ajit spoke about this. We're kind of cutting to the chase here. We want to get to the point.
Correct.
Key is you don't want to be too far away.
Right.
So you kind of want to get an idea of where your external iliac, internal iliac is. Where you think it is. Almost draw like that imaginary line in your mind, looking at the contralateral iliac, because likely most iliacs look the same on both ends. So it looks like it's making a curve the way the other one is. So let's see. I mean, we're just going to go. So Raman's got a smaller loop, and he's going to take it up, and I'm just going to track the catheter with him, lower the loop a little, Yeah, because once you make the dissection plane too big, remember, when you're trying to re-enter, you don't want to have too much of a dissection plane either, which is going to make your life more difficult. So here is when you really need to see. See, it's making the turn.
That's very important. Very important to look at is the turn. So Atul, what do you think? Any special comments on that?
So I think one thing to always keep in mind is always make sure you have live pressure. So you have aortic pressure live on screen, watching it all the time. Because when something goes south, it goes south very quickly.
All right, now
try not to oversee the feeling of back pain or pain right away. The most complication is perforating your iliac in a retroperitoneal space where you have no ability to compress it. So I love the idea of having two operators. I think Vishal knows I do these cases with him usually. I like to have a second operator in the room. I don't think there's any need to be cowboy. Having a vascular surgeon is a super added bonus. But always have a live pressure tracing and always have a second set of hands, because if you have a complication, a rapid response can take you out of the bind.
Right. Well, this looks great. I mean, it's pointing towards the iliac ostium. So I think it's heading in the right direction.
Well, mine, both Osman and I have a little advantage because we know what happened last time. So it kind of took a little bit of the similar turn, and what's probably going to happen here is it's going to go medial, and it's going to go underneath. We'll see. The question, how many of you would lose the loop? How many of you would continue the loop? I know it's a very controversial kind of topic here because nobody wants to dissect into the aorta. Because I think here, if you're not thinking about dealing with the distal aorta, one of the decision points for the vascular surgeons and the cardiologists out there is, okay, it's a claudication. I'm not dealing with that distal aorta. I just want to deal with the iliacs. So if you dissect up into the aorta and re-enter high, now you're going to have to talk about, bilateral stenting versus dealing with the distal aorta. So I think this is an important point. That's why I asked Raman to just slow down a little bit. I know he would have probably crossed, but just to get an idea on where we are and make a decision. Ajit, I think you're the best at commenting on that.
Yeah, I think my personal preference is to J it all the way up to the origin where it comes back, and then to actually lose the J and just try to carefully pop into the lumen, because as you're kind of alluding to, one of the problems is if you keep going higher, you can dissect into the aorta, which obviously carries, I think, an additional risk. And then the other caveat to that is you have to do kissing iliac stents. So going along with planning, I think it's important to look at your distal aorta and just plan ahead. So in this case, I'm a little bit worried just because the distal aorta is very small. It almost looks like the same size as the right common iliac artery. So trying to put in two large iliac stents, they may not do well in the long term.
Exactly. And I think so. So what do you think, Vishal? I want to lose the loop. I know that. I don't know about you and Raman.
I agree with you. I mean, losing a loop here would be probably a smarter strategy. But just to add on to Ajit's talk, I mean, it's a very calcified lesion, so expecting it to re-enter right at the ostium is probably harder. I think you could try to dissect it a little bit higher up, but the biggest concern would be not losing that lumbar collateral, which is supplying all your left leg. Yeah. So losing the loop, like you said, rightly should work, and then try to re-enter as much more distal to the aorta as much as possible. And of course, we have additional devices to re-enter, which I'm sure you probably might try again with Ajit and you being there.
Well, yeah, that's
as a secondary option.
I think that one of the things, I mean, Atul, any comments before I just talk about what I think we're going to do?
No, I think I have the same comments. I'm more concerned about losing the lumbar. So
I think
too. Taking the loop out and trying here.
That's still quite high up.
Yeah,
but that's what I'm saying. So you have a room for dissecting. Correct, exactly. So you still have a little bit of room to re-enter.
I think Ajit's point is that distal, if you're landing too much metal in that distal diseased aorta, it's going to create a problem in terms of, flow dynamics, possible thrombosis, so on and so forth. So I think, especially since we're thinking about this, I think, and knowing, having, like I said, Osman and I having done this case before, I think this is where we were easily up to here. So the question is, how are we going to re-enter? So one of the things I want to do is to just give it a quick tickle with both Ajit and Raman trying, since I tried last time. And if we can pop in here into the with the wire, great. If not, I think we just go with the re-entry, because we know we have no support coming from the other side. We tried putting a wire from the other side to come down. I could try on this end, trying to put a wire and come down, and while Raman tries from this side, and then see whether we're able to, snare the wire from below. We could try that. We could try a lot of different things. The only thing that would really sit last time was not a UF catheter, a IMA catheter. So maybe get an IMA now and then try to do that. I don't know. So at this stage right now, we just have to figure out what we're doing in terms of what we want to do. So why don't we just try to tickle it with an 014 wire? So lose the loop here, since we all agree. And what wires do you normally try, Ajit, in this kind of cases? I'm curious, vascular surgery-wise, what wire do you guys try?
Yeah, I think for this, I would probably start with a floppy glide wire and like a glide cath or quick cross, and then kind of upgrade, stiff glide wire. But for iliacs, I typically just stick with 035 system, because the stents that we use typically go through 035, and if you need to put in a covered stent quickly, you don't want an 014 that you can't track your big stents with. But yeah, floppy glide wire and then stiff glide wire and like some sort of angled catheter.
Facing up now.
Yeah, I think that's a very important
There's
point.
the stump right there. We're just going to try to rotate the catheter up. I'm going to help him just rotate the hair. I got the catheter.
Laterally. Yeah.
There you go. See how it's sliding? Yeah. That's what kept happening last time. Maybe it's right here. We'll see. We're going to just jam it up against what we think it is, and then go with a floppy glide or whatever you want. It doesn't make a difference to me.
The other thing I like to use is
while we have you here, since you're a little different.
Okay, try Confianza, guys.
What do you think about doing an axillary cut down or a brachial cut down for axis, given the fact that last time the femoral approach wasn't successful? Of course, we have a different strategy now.
Confianza, guys, Confianza.
Yeah, I think that's a great point. I think for this you probably need a 7-8 French at most. So probably a brachial cut down would work. If you were trying to come from above, and if you were trying to be very aggressive about an endo approach. But kind of to everyone's point, going from the contralateral femoral is not a good option, because you just don't have any pushability.
Yeah.
The only other thing that I've seen more recently is trying to use steerable sheets. If you have a little bit of an origin that you can kind of seat your sheath into, but even then it's just not the same pushability as coming from above or below.
Yeah, I mean we have steerable sheets, as you know, in EP as well as we do as well. But I think the problem here is I think for me a cut down is, we have the Pioneer here. Yeah. We can just use the Pioneer and pop in. We have contralateral access. We have the equipment. We kind of planned the case out. I just don't want to extend this above.
Correct.
And I think that it's going to become an issue if that distal aorta becomes involved. We're going to have a snare here just in case we were able to get in somewhere in the aorta. We can try to snare it in the aorta and then work from up and over. We have a lot of different plans, but we're just going to go ahead and just wire this just for a few minutes. Yeah. It doesn't work. We're just going to go.
We're already getting blood from our.
Yeah, because we created a nice track.
Yeah.
Yeah.
Well,
You might need even a little bit more stiffer than a confianza. Of course, confianza is good to have a feel, but probably use a little bit more weighted wire, like a Stato 30, 40, or a Win. Might give a little bit extra support in this case.
Well, the
Iliac.
problem with the Win, I think, is it could once it gets entangled in calcium, it unravels.
Correct.
And I don't want that to happen here. Confianza also can do
Stato works.
Stato usually doesn't, and hopefully you'll feel it, and hopefully it'll pop in, and sometimes you've done a lot of dissection the last time.
Correct.
And because of that, it doesn't work. I'm going to pull back a little, give him a little more action. Yeah, try that side there. Yeah, maybe there. No, see. And this is the problem I was having last time, and you'll see it'll go there, it'll go above, it'll go.
You're right. It just spirals around.
We tried changing
there
different
That's
direction.
a little bit better direction, Raman. That's it.
And it'll spiral around the aorta. You'll see. Hopefully. Oh, this is what it did last time, brother.
It's outside again.
So yeah, so I think that you're definitely outside. Yeah, it's outside. The same thing it did. So I think that what we may do is just cut to the chase here, and just go with our Pioneer. Yeah, because that's going to take a little bit of planning, and then once we do it, snaring the wire and doing our work. So it's going to be, we'll try a few minutes here, but I just don't think this is going to work. Let's see.
I think you're right. It's spirling around there, right there.
Well, we'll see. It moves well like that last time. Let's see how it looks on this side. Let's see if it goes. It should get stuck right there. See? Yep.
Yeah, it's going all the way around.
Yeah, that's what happened. It's just spiraling. Yeah. All right. So you want to just do the reentry?
Yeah.
All right. So we're gonna just do the reentry. So we have a track. So give us the Pioneer catheter now, guys. Pioneer. You can walk. Let's put this one. I want a grand slam through this. Give me a grand slam.
Yeah, so Pioneer is a great reentry device in this case, especially in IVUS guided. You don't want to take the second guess out of the game. So in this case, Pioneer would work better. I mean, of course, if you don't have it, Outback is the option. But if you have an option, I think Pioneer is a very good choice to pick, especially.
So again, for everybody in the sheets, and the anticoagulation, we've given about 5,000 of heparin. Liz is watching our ACT. We've got Dame. We've got the aortic occlusion balloon just in case, right? We got the aortic occlusion balloon. We've got we've got our 11 French sheath. If we need to upgrade it to, we'll have that ready. Just basic stuff here. We're just going to loop this up there, and we'll just go with the Pioneer. We'll just decide.
Yep, sounds good.
But I think that's on this aortic occlusive balloon. Which one you have there, and maybe some of the newer balloons.
Well, I don't remember. Which one do we have? You want to comment on that, Ajit?
Yeah, sure. So we have the two ones that we have here are the Reliant balloon and a Coda balloon.
Yeah.
So I think they go through 11 or 12 French sheath. So having that sheath available, having the balloon in the room, having covered stents are all important, because as we've kind of been discussing multiple times, one of the real risks is rupture. So you need to have everything ready to go, because seconds will matter if that happens. But that's what we have here.
No, I mean, that's a very good option. You like Atul was pointing out, knowing your balloons and knowing your devices is very important, especially in these cases. So whatever you keep in 11 French, 13 French, you should have a good one aortic occlusive balloon, especially in these cases. So
I'll give it to you.
Makes perfect sense to have them on standby or backup. So.
All right. So while we prepare this, we're going to get everything ready. We're going to have Osman give the quick lecture, and we'll do this. Let me give an ACT for her. We're going to have Osman give a quick lecture, and Ajit and I will just comment with the Raman on our steps as we start.
So going back to the considerations of these cases, we talked extensively about this, but access is important. 6 to 7 French sheaths for some of the Vibon, for the covered stents for these Iliac CTOs. Sometimes you even 8 French. So important to have all that ready, just like we do here. Wire-wise, it's variable. You may start with the 014, upgrade to 018, and then 035. I think that's somewhat more operator dependent. You don't want to over-sedate these patients like we were just talking about. Obviously, rupture is a concern, and so you need to have covered stents available in the room, obviously, for these cases. Other considerations for the aortic iliac CTOs is the location and the extent of the CTO often determines the access site and the strategy. So if you have bilateral common iliacs, like we talked about, you can consider bilateral common femoral or radial access, like we were talking about earlier. Bilateral occluded externals, you can try a brachial or radial along with ipsilateral SFA. If you have an external iliac occluded, you can consider contralateral common femoral up and over. and then common iliac extending all the way down to the CFA. Again, radial or brachial is an option there. External iliac just covering the internal. Contralateral is usually sufficient in that case. So this is the task criteria, just so we can communicate with other people and vascular surgeons, endovascular professionals. Task A to D, the lesions basically essentially get more complex as you go from A to D, more diffuse disease, more CTOs, more calcified, more aortic involvement. Historically, the task D lesions have been done more, we've reserved those more for surgery, but as you can see in our patient with all her comorbidities, usually, not the best candidates for aorta by femoral or fem-fem. So we've moved more towards an endovascular first approach. And there is data that supports this, like the 24-month trial from data from the Brevismo, which was a prospective trial looking at task A, B, C, and D lesions. As you can see here, the patency for these at 24 months, regardless, irrespective of task classification, was similar, suggesting endovascular approach is definitely a viable and good option. As long as you discuss it with vascular surgery and you've discussed the case. Aortic iliac disease oftentimes begins at the aortic terminus, and the common iliac progresses proximally distally. It can extend to the renals. When collaterals are adequate, sometimes these patients can tolerate aortic occlusion very well and have stable claudication symptoms for several years. There's various collateral systems that develop, and we'll go through those here shortly. This is just a general schematic of the iliac artery, common iliac bifurcating to the external and the internal. Very important branches here that are important in the collateral systems. So off the external,
211.
You can have the deep circumflex, the inferior epigastric. Off the internal, the gluteal systems, the obturators, as well as the lateral sacral. Over here, some of the collateral circulation. We were talking about the lumbar, in our case, the big collateral. You'll see that over here. But if you have an external iliac occlusion, oftentimes you can have the subclavians come down. We have the IMA provide the superior inferior epigastrics. The deep circumflex off the external can anastomose with lumbars and intercostals. That's another system. The iliolumbar collaterals with the lumbars and intercostals in the case of internal iliac, and then the medial sacral to the lateral sacral off the internal iliac is another collateral system that we see commonly. We'll talk a little bit here about the radial sheaths that we have. So we use this R2P sheath, which is a 6 French sheath. It comes in 119 and 149 centimeters. It's a hydrophilic sheath, so very important to wet it down. In these cases, spasm is a big issue. It's a longer sheath than the coronaries that we use, obviously. So that can be a huge problem in the case. So you definitely want to take those precautions. As far as radial cases, so sometimes you can see as that it's a small picture, but up there on the left, when you have, similar to our case, that blunt occlusion in the common iliac, sometimes you have a good favorable angle coming from up top, which is why a radial or brachial sometimes is helpful, makes it a little bit easier. Obviously, patient comfort, lower rate of bleeding from radial, always good. You're limited a little bit with atherectomy decisis from radial, so CSI most commonly used, but difficult to get past the distal pop in those cases. Obviously, your bailout options are limited as well because it's a 6 French system, so you need to have a 7 French system in the femorals for your bailout stents. And then again, spasm is a big issue with the radial, so you just need to be aware of that. The elderly females, the anxious patients, the smokers, and those with known vasospastic disease. Other equipment from the radial, so there's two balloons from Terumo are the Metacross, the 03 going over an 035 and the Crostella over an 018, and then the Misago self-expanding stenting system, which is a 6 to 8 millimeter up to 150 millimeter in length. And then the Metacross is a 3 to 8 millimeter balloon up to 200 millimeters in length over there. Obviously, with radial access, like we did, ultrasound is reasonable if you have that available in your lab. Using a wet 4x4 because it's a hydrophilic sheath in your front hand and back hand, a dry gauze to push it forward. And obviously, giving your radial cocktail, whatever you give in your lab, is very, very important. Spasm is, again, a huge issue in these cases, so you want to make sure because it's a long sheath, that you do everything to prevent that from happening. This is just some data from a single center. It's a schematic essentially of scenarios which favor transfemoral versus transradial, and these R2P cases from a single center trial in 2016 comparing transradial versus transfemoral for aortic and fempop interventions. Essentially, I like the schematic, so I put it up here. They were just looking at scenarios where mostly we go femoral for these, but there's a few cases where radial might be good. Again, when you have that blunt stump in the iliac and you have a favorable, for a CTO, favorable angle to get in, you may try a radial if you've tried the femorals before. Left radial, a little shorter distance, so you may gain 10 to 15 centimeters, which is great. So for a peripheral case, you may try left radial first. A little bit less radiation, and obviously when you have these hostile groans, multiple prior interventions, prior surgery, obviously in those cases, radial. You're limited by equipment in the radials. You don't have the drug-eluting stents and the DCBs, so something to consider there. That's the main con. Pros, again, safe and effective, quicker discharge, patient satisfaction, and now possible for iliac and femorals. The cons, again, it's mainly the equipment and the radials that you're limited by. The woven nitinol stents, the DES, the DCBs, you don't have those readily available in the radial cases.
Lundquist wire.
So these are some of the re-entry devices we use in our lab. One of them is the Outback over here, made by Cordis. This device basically goes over an 014 wire. Again, you dissect subintimally until you get to the area of reconstitution, and then you deploy your 22 gauge needle. You can have a balloon from the other side as well, puncture the balloon, have the 014 wire go in there. As the balloon deflates, it captures the wire, and then you can externalize it. A little bit more sophisticated device here is Pioneer Plus re-entry CTO device, which we have over here, which is really nice. I'm going to show you a nice video of it, which helped me to understand it a little better. But again, this is goes over an 014 wire. The catheter is advanced into the subintimal plane beyond the distal cap, adjacent to the site of reconstitution. And then you use IVUS, which I'll show here in a video. But basically, you change the IVUS. You move the IVUS till you see the true lumen. Then you deploy your needles. You have a 3, 5, and millimeter setting on the needle, so you can measure on IVUS how far you are to the true lumen. Deploy your needle out. And then kind of get into the true lumen that way. Put another 014 wire through the back, and we'll show that over here right now. So this is the Pioneer Plus system over here. A little demonstration of how it works. In this case over here, they're dissecting subintimally with an 035 wire, as we did with the stiff angle glide wire initially. So kind of essentially doing something very similar that we just did over here, which is nice. So gotta
get a feeler.
Here's the 035 wire. They're dissecting here. I'm gonna go subintimal. So once this wire gets through over here, they advance the device, the Pioneer Plus, over this device. They're gonna switch for an 014 wire now. So here comes the device here. You have your 014 wire coming out, and then they're going to put on IVUS over here to take a look. So it helps you essentially sort of, now you're looking on IVUS over there. You want the true lumen to be at 12 o'clock. So you have chromoflow on over there. You can see the blood there. You get the blood at 12 o'clock, and then you can measure with obviously those marks, as you can see on the IVUS, to see how deep you are from your lumen. And then as you can see, they have those settings. You twist that top portion up, whether it's 3, 5, or 7 millimeters, and then you push the blue up to deploy your needles out. Once your needles are out, pretty straightforward. You just put your another 014 wire through the back of the Pioneer Plus, and you're now in the true lumen. You walk the Pioneer Plus out, and at that point, you go on with your case. We'll just conclude here talking a little bit about the choice of stents in the iliac interventions, balloon expandable versus self-expandable, and then the covered versus the bare metal stents over here. So as far as aortic iliac disease, the stent types, you have the self-expanding nitinol stents, the covered stents, self-expandable like the Viabon, balloon expandable, and then the balloon expandable covered as well. The balloon expandable stents are better for lesions with high elastic recoil, so the short, calcified, eccentric plaques, better for accurate placement. The self-expandable stents better accommodate more tortuous vessels like the external iliac. They have increased flexibility, but decreased radial strength. So also good for vessels with transition size, for example, the common iliac to the external iliac. Not a lot of data on kind of what stent to use where. So, ICE was one of the first randomized trials to sort of look at the bare metal balloon expandable versus the self-expandable stents. They randomized 666 patients to common iliac, external iliac, 18 sites, balloon expandable versus self-expandable, Visispro versus the Protégé. And essentially the restenosis rate was lower in the self-expandable versus the balloon expandable. Though the patency for both of these was very good at 1 year. So again, you're not going to be dictated by this. Obviously, if you have a highly calcified CTO osteal lesion of a common iliac, you're going to use a balloon expandable most likely. So it just depends really on the scenario.
Although in the highly calcified lesions in the hazard ratio, the still held up that self-expanding stents were good.
Yep. So as far as the covered stents go, again, self-expanding balloon expandable, you'll probably use these more, again, when you're worried more about really calcified vessels. CTOs more likely to rupture. The advantage of these stents. You need a bigger sheath size, obviously, so you have to plan ahead. The COBUS trial looked at covered versus bare metal stents. These were all balloon expandable stents, 125 patients, iliac disease. Primary endpoint was freedom from restenosis or stent occlusion. Covered stents had higher patency at 18, 24, 48, and 6 months. Some of the postdoc analysis showed that really in the TASP lesions, it didn't make much difference, so equivalent, but this was more seen in the TASC C and D. So in TASC C and D lesions, the CTOs highly calcified, maybe more of a role for the covered balloon expandable stents in that case. Just to summarize here, again, we've talked about this, but so self-expandable stents, highly flexible, maybe favored in the external iliac, but again, less predictable deployment than the balloon expandable. The balloon expandable increased radial strength, maybe favored in the aorto-osteal lesions, the more calcified lesions, and then the covered stents, you're going to kind of reserve those if you want to exclude thrombus, maybe associated with a little bit of improved patency in the TASC C and D lesions.
Nice job. Very nice tour de force there of presentation. So anyway, listen, so we're going to get to it. I want to stay within the hour. So we are just going to loop this wire next to the aorta a little bit. And then right there, probably leave it there. So what we're going to do, guys, it's a little different here than our SFA like we talked about. So I'm first going to get this up. Ivis is hooked, Dame. Ivis is hooked up. You can't have much damage here of the catheter as you go in because you're not going up and over the arch. So I'm just going to track this up, and then we're going to have a little discussion here. Obviously, it's not tracking as we thought it would. There it goes. A little bit of pushing. It did track. So the question is, where are we? Do we need to be further to the side of the aorta? We'll find out in a second, and that's what we're going to have to discuss. So let's put Ivis on for us and see what we're looking at. Remember, we have the iliac veins here as well. So we have to be a little cognizant of where those veins are. And we also need to see where we are in terms of firing this needle. You can see the Ivis catheter is proximal. The needle is distal. So we need to just, let's go live with the Ivis for now. And I want you to see where we are. We don't see much blood, so we're not close to it. So the question here is, do we need to reposition the wire before we go? Right?
Yeah, I think you get a little bit more proximally up to be just closer to the lesion.
Maybe. We might have to just reposition the wire, which
so if you see
we'll do. Let's just take a DSA here.
Yeah. If you see the chroma flow, it's just next to it as well.
Okay, we're not quite close to it. So
correct.
As you see, we're probably going to have to go next to it in order to do it. So you can see that the vessel, the calcium is moving. So the other point is to try to stick the occluded vessel and then go up with a wire across the occluded vessel. That's another one by using the calcium. So what I'm going to do here is just try to advance this wire into another plane. Let's see if I can do that with limited ability to push, let's say.
Yeah, it'll be harder for you. You'll keep going into that same.
Yeah, it's going to go into that same plane, isn't it?
Yeah, I think you can go a little bit more up and try to fire your needle, like you said, and see if you can find a true lumen. It's right now at 1 o'clock.
Well, let's see if I, right around there, maybe. Let's see.
Now, now it's very occlusive. You're like.
Yeah, so this may be, let's see, no, there's no flow at all. I'm rotating my IVUS to see where we are. What happened to my IVUS image?
Did it break?
Did it break? IVUS, guys? Let me pull back a little here, maybe.
Yeah.
A little shimmy here.
No.
Looks like this is the beauty with the IVUS catheter.
Wow.
Wow, it broke.
Already broke?
You can give it another 1,000.
Yeah,
wow.
IVUS image is gone, guys. IVUS, what's going on with my IVUS?
Wow.
Well, you need a new one. Yeah, I mean that was minimal manipulation. It was like nothing. Wow.
Yeah.
Impressive.
All right, so let's walk this out. I'm going to reposition my wire, and then we'll flush this and see if it works. So give me back that vert tip catheter, guys. So again, this is why I'm saying it's a little different than the SFA, right? You want to be side by side, can have the vert tip, but you don't want to be too much to the side. If we, so give me the nice thing was we're not in two vert tip catheter, guys. So nice thing is we're not in too much of a dissection plane. We're not in too much of a dissection plane, which is good. So I'm just going to give this to a JIT, and I'm just going to go up and try to manipulate it a little bit more to the side of this vessel. And then we'll try to enter. So this is what Ajit and I were talking about earlier, was whether we're going to do the kissing stents, because we felt that we might have to just kind of hit both osteums, because we might be side next to the common iliac sort of nubbin that we see. So he's going to pull me to him. And so
this case might be a little bit higher chance of doing a kissing stent, which I don't think is
well,
wrong.
Which we're ready. We're totally ready.
Yeah.
I mean, we're ready for everything. So what I'm going to do here is just pull this wire back, and give me a glide wire here, or give me another CTO wire.
But the question is, what's the status with the right SFA CTO?
It's still CTO.
Same one.
Oh.
No, I need a glide. Give me an 018. This one. What is it called? 018 Terumo gold tip wire. Yeah. So, Ajit, any thoughts now with what's going on here?
Yeah, I think what we're kind of saying, we have to get our wire farther up.
Yep.
Right, because the needle of the device is not like at the very tip of that, so you need like a little bit extra to kind of get your needle in position to where the artery actually comes back.
Yeah.
I think something has to go up a little bit more. Yeah.
Yeah, I mean, I wouldn't necessarily think about it here, but for the SFA, sometimes like a balloon angioplasty, the end of it, to help the outback track a little bit better. But in this case, obviously, it's higher risk, so I probably wouldn't do that.
Just give me a V18 then.
Yeah, we just need more support.
More support, more distance.
You have a V18?
The other caveat to that is it's good to start lower down, and burn less bridges, and then kind of work your way up. So
right. That's why I'm being a little careful here. Right.
Yeah. I think that's not a bad strategy. The more closer we are to the cap, the hoping of capturing through the subintimal place will be easier with Pioneer. It's just because, like you said, the needle is more proximal. So even though IVUS might be touching right at the origin of the iliac, because the needle is more, more distal to the cap or more towards you, the firing will still happen probably in the occluded segment, which might make it a little bit worse. So you might have to protrude, be a little bit more aggressive with your Pioneer and try to direct it into the distal aorta, so that the needle is still in your common iliac. That's
so I'm just going to work. Well, I'm just going to work this up a little bit here. I'm going to try to torque my catheter away to the lateral side here. See, we'll pull back a little, try to get another plane. See, that's the plane we don't want. There we go. There, a little bit better.
That's better, yeah.
Yeah, let's see if we
I think that's a better plane.
But it's still not going there. Push it up, Norman. Let's see if it.
But I think definitely it's a near plane. So hopefully it's just probably breaking. I have to break through the cap. But I think I like that plane better.
Yeah, see, it's somewhere else now.
Where?
I don't know. Let's go to a different view here. Sometimes, you get fooled by your views. So it's important to see where we are. And we're not in a bad area. Okay.
Yeah.
So give me now a confianza, guys. Let me try to go a little further up the other way. I don't know. Pull back a little. Let me see.
I think this Pioneer catheter it's really meant to. You have to have some distance after. So I think it's very hard to place exactly where the needle's going to go through. So I'm more
There you
convinced.
go.
now.
There you go. Ooh. So I think taking a, yeah, no, I
Don't worry,
agree.
I'll get it there.
Extend.
We could take an Astado, 30, 40,
track-
and yeah, right there, where it knuckles.
Track it.
That's
Let's
a
see.
good point to enter.
Oh, let's see. Okay, now give me a.
Take an
Okay, now
Astado.
give me an Estado or something. Oh, what do you have there? Confianza? Huh?
We
Yeah,
have
give me
a,
that.
we have a Confianza in the back.
We have it already. Let's just try quickly. I just want to make sure that we're in a different we're in the right planes. As long as we're in the right planes, I think we'll go very quickly into this.
Yeah, I think this might be a better spot
wrong end
because you're
again.
technically in the distal aorta right now. You're not truly in the cap, but you're in a different plane for sure.
The problem
gives you a
is
little bit
that
more
we're gonna have to slide above.
Yeah.
You know, and that's the only thing I'm worried about here. I'm just gonna go AP. One of the things I think the people at home have to understand is that the views are very, very important for you to make sure that you're gonna enter in the right spot. Yeah, that's a lot better here.
Yeah.
Let's
You
see.
just kind of poke right into it.
Well, we
Would
pray,
be nice.
but you know, it would be wonderful, and we don't have to go through this whole exercise. But we'll see. Let me just start together.
Yeah, see.
I'll pull it back a little bit for you.
Yeah, pull
Yeah,
back.
no.
You got it a little bit.
I'm definitely interacting with the aorta. There you go.
Nice.
I think we're in. Yeah, we popped in. Yeah, we popped in. Looks like it.
Ah, see?
Hold on.
Yeah.
Forrest, you have that?
Well, no, so much for the pioneer. Flora,
Help create a
let's make sure we're not in the vein.
Get the money back.
Hopefully we're not in the vein, Flora. You know, guys, I mean, you know, one of the things that Ajit will tell you, like, I'm sure anatomically the vein is right there, right, Ajit?
Yeah.
But does this look like the artery, though? I think so.
Yeah, it's very close.
I think we
Yeah.
had to go up to the arch now.
Let's
I
go
hope
to the arch. Raman is like, we're going to go everywhere.
Raman is like,
You want to snare it now? What do you want to do?
you want to do a right heart? No,
Let's-
I think
let's
it's a
push it
stiff
up, push
wire.
it up.
You should be able to get
Push it
your.
up. No, push up your other catheter.
Yeah,
Let's
we're
do an
No,
aortogram.
this is not going to go.
Oh, this one. Push this one up. Yeah.
Probably do a.
Now let's make sure we're in the aorta here. Let's do an aortogram from this side. All right, guys.
Navi
Sitting.
cross or something.
Where's our? Oh, he's got it. Yeah, I think we're in now.
Yeah.
All right.
I mean,
all right, beautiful.
you can flip your the catheter right there, and it's going to interact.
Let's see
with
if
the
Raman
wire.
can do it. Raman might be
Let's
able
see if
to.
we
Oh,
can
that's a good. But I think we're in now, Vishal.
No,
I
I
think we're
believe
in.
you. I'm
There
just
you
saying.
go.
There you go.
There we are.
Not quite. There you go. Okay, Raman's popped in. Push it up now. All right, now give us a. Let's now always check pressure. There's the one thing I want everybody at home to be careful of. You know, yes, you have an 035 hole, but you have not ballooned. So now we're going to go with a pressure check, right? Which is very important. Make sure your pressures are matching, and they are. That's an aortic. Show the screen, guys, so you can see the aortic pressure, the white mat. Can you show the screen, guys? Can you see the white matches the red? So we're in the aorta.
Supercore.
So if you really want to just be even more sure, do the old thing.
Yeah.
Jack from over here.
Yeah.
Well, I
Well, I gotta admit, Ajit was saying that we might be able to just get through it, and it did work. But
Yeah.
let's sit
I
in.
had faith.
Yeah, no, you did say you were like probably will pop through.
Yeah, I think the
now-
wire selection and of course the new plane
There.
and the
Okay,
wire
good.
selection really
So now
made a big
Lunderquist,
difference.
what do you want to do? Lunderquist now?
Amplats or Lunder.
Amplats. Oh, we have the Lunderquist open, right?
The Lundquist was in the back, right?
And-
So
Right there.
I guess the biggest
Actually, give us the
question.
Amplats then. Amplats super stiff.
So
But
the
now
biggest
how are we going to
question
deal
for,
with it?
right. So the biggest question for the audience and everything is number one is where did you enter? Because remember, like we've always been talking since we started the case, where we enter will determine our treatment strategy: bilateral iliac, unilateral iliac, saving the collateral, covered stent, all those things.
Oh, I think it's okay.
So I know a tactile feel of where you entered is important as well. But what other strategies do you really use in this case to determine where you entered and how you're going to treat it?
I think
Atul,
we
do you have any-
entered
Right at the
we
nub.
entered right at the nub.
Yeah.
Okay.
Yeah, I think
well,
it was-
I think you ended above the nub.
Yeah.
Okay.
So I think so I'm sure Ajit will agree with us, is like the way to determine is probably I know we probably waste an extra money and probably do an IVUS.
Oh, you want to do an IVUS? Then we got to put an 014 wire, guys. 014
What do you think,
wire.
Ajit? Let me ask Ajit too.
Yeah. I mean, I think in this case it was pretty clear where we entered, but I do think an IVUS would be good.
All right, let's put a grand slam up and do a quick IVUS.
Grand
Yeah,
slam.
for two reasons. Number one is
Pretty good,
to obviously
Sizing.
confirm where we
already have
re-entered, and
the
then
grand
number
slam.
two is for sizing.
For sizing,
Is-
exactly.
Would you
It's,
dilate a little bit would you take a small balloon and dilate a little bit? I don't know if the IVUS is going to go with the 014, but it may get damaged on the way up also.
Yeah, I think it should track. Let's see. I mean, it's a stiff 014 wire, and it's an 014. I mean, we'll probably use an
0.8
035 IVUS.
Mhm.
No, 014 IVUS, because 035 you need a 9-French system. We have a 6 or 7, so
Yeah.
I think an
We have
018
we have an
IVUS will be
018
ideal.
IVUS.
Yeah,
Yeah,
018
we
IVUS
have
will be
one of it.
ideal. Perfect.
So Abdul, you know, that's why, you know, the younger generation is lifting weights and working out like Ajit and Raman, unlike me, you know, who the only thing I lift is a glass of wine.
Hey,
So, you know, it's a little different. It's a little different. Peter and me are different.
Those are heavy
But
sometimes it's not the weight, it's the repetitions.
Exactly. I was gonna say, the weight of that glass of wine on
The amount of times
is
it's
much
going
more
up and
than-
down.
I know Dr. Guja is washing at home and shaking his head. I know it. So, you know, this is the thing. All right, let's walk it out. So, guys, you may get a drop in pressure a little bit here. Don't get crazy because then you've created an 035 hole, and we're in a subintimal space. So we're just going to watch this quickly, and we're just going to do a quick IVUS, and then we're going to go ahead and do a, like we said, we're just going to go ahead and do a balloon sizing. So Ajit, now I think this is where you can really teach us a lot. What are the things that you're looking for balloon with the IVUS? Well, tell me what are the things your eyes are going towards.
Yeah, so I'm looking at two things. Number one is the endpoints. So where the lesion starts, where it ends, and what the sizes are there. Because we're going to have to, you know, we're going to pre-dilate most likely, be my guess. But, you know, but then obviously you want to get your sizing right. Because if you rupture with the stent, you know, and it's undersized, it's going to bleed potentially. So looking at the endpoints really carefully. And then the second thing is also seeing where exactly we re-enter.
Beautiful.
Okay.
Because that's going to determine whether we need to do kissing
Now,
stents or
now
not.
can you change the what is it called? The size, guys?
Yeah, it's
Yeah,
at the
so
max.
it's at the max. You're in the distal area. You'll come back a little
Where's
bit.
the high up?
All right.
then-
Way
so,
high up.
So Raman's going to go ahead and do a pullback record, guys.
Yeah, so I think Ajit is perfectly right. I mean, the
Okay.
IVUS in this case is very essential for sizing specifically, especially you want to get a good optimal size and expand the stent to its maximum capability on the vessel wall. So the good thing about these Viaband VBXs is they are balloon expanded, so they can expand to all the dimensions from 8 to 12 to 14, depending on how it is. But now the question is, we don't see
you're just
fluoro
with the
on, we
order
see the
there.
IVUS. Can we put the fluoro on as well, just to give an idea of how the IVUS and the fluoro interact? Yes, please.
So
Thank
right
you.
here, we're right above the bifurcation.
Right. If you can do a small test, just to PK, can we do a small test through the
Yeah, sure.
just to get an idea, just to show to the audience
Yeah.
the IVUS, the fluoro? Yeah,
distal.
perfect. So we're still
Now
in the
they're coming
lumen,
back.
and
There's your
That's your
left coming off,
bifurcation.
And now
That's your
here we are in the right. Let's measure this.
Mark,
We agree that's
so we're still all intraluminal still,
still
Yeah.
here.
which is
That's,
great.
That's the osteal.
And
Oh,
there
yeah,
you're going to
okay, now
pop in,
this
right?
is- here we
Yeah,
are
that's your
gone.
subintimal space.
what's up, Liz?
Perfecting all the
Yeah,
way.
so
Yeah, yeah. So it's good. So you entered right at
See all
the
the
at the
calcium.
junction.
So the question
It's
now
all subintimal.
the question for Ajit is shockwave, no shockwave, balloon angioplasty, crack and pave, you know,
yeah.
all the other things that we need to discuss on this kind of cases.
Yeah, I think if you're worried that your stent's not going to fully expand, then shockwave is good. Because regardless, we're going to use a covered stent
Right.
and, you know, crack open the calcium and
So I think Ajit wants to also measure the distal at the
Yes.
common femoral junction. So I'm going to just go
Wow,
ahead
that's a
and
lot of disease or subintimal, right? Pretty
yeah.
impressive.
And
Now
here
we're
we
truly-
are. And
Here we are, true
Mark that
luminal.
bookmark.
This is the
Yeah, you have to
proximal
extend your stent
CFA.
almost here.
All the
Oh,
way
that's
down.
what we're talking about, whether we do a
Yeah.
covered or a self-expanding, and there's our catheter.
There we are.
Okay.
All right.
All right. So now let's talk. Let's do those measurements, guys. The Mike, the proximal, and the distal, please. And then what size balloon? Balloon sizing now. What size balloons do you want to? Now let's switch out for a Lunderquist
Yeah.
wire.
Get the
Let's have our
aqua
accesses.
tempo again. The aqua.
Yep, Aqua Tempo
Yeah.
or Lunder
So-
or which wire? The Amplats. We have the Amplats.
Yep.
Sorry.
Probably.
so I'm pretty
maybe 8
conservative with pre-dilating for iliac lesions. So
What do you normally do, Ajit?
like 4 to 6 tops.
4 to 6.
Yeah.
Okay. All right.
then-
So let's get a
HCTZ.
5.0. Let's cut it in half. Get
Oh.
a 5.0 100. And let's just make a balloon here. A 5.01 long balloon, Mike. If you give me a 120 is fine. Whatever you got long. I need an 035 if you got it, Mike. We're gonna go on an 035.
And I think it does two things. Number one, it's going to help track our stents. But number two, if the balloon
long as
fully
you got, yep.
expands, I think that's usually a good sign that your stent will also expand. And you probably don't need a shockwave. So that's one of the ways
I
I
see
kind
what you're saying. So 5.0 is good enough right there, huh?
yeah.
Laura? Yep.
And also, I don't see a lot of calcium on the, you know, fluoroscopy, and it looked more like soft plaque to me in most areas.
Yeah.
I don't know. What do you guys think?
There were
I
a
think
few
distally
areas
there was
with-
calcium,
yeah,
but you're
there were
right.
a
I
few-
think
few
majority
areas.
of the rest of the lesion was soft flack. Yep.
Yeah.
All
I
right.
think
Yeah.
Amplats.
So again, IVUS helps you figure that out
Yeah,
as well. So yeah, soft plaque
sorry.
is good. I would probably be a little bit more aggressive. I mean, the vessel size is pretty generous. So maybe like a 7.0, which we usually do in the lab. I mean, I'm sure PK and Raman agreed to it, but 5 or 6.0 is great to start with as well. But
A 7
this case,
pre-DIL, you're saying.
correct, pre-DIL, yes. I mean, I think we can get away with 7.0 in this case if we have to. But again, doing a 5 or 6.0 could be fine.
Yeah, I mean, it's
a good size vessel
does
if
it
you really
say?
do the measurement.
Yeah.
I'm just
It's
gonna
almost
hold the
11 to
screen here.
13. And
the
all the way
other
down,
thing-
it's almost like 9.
And the other thing is to see if your calcium's circumferential or not, because if it's
Renal.
circumferential, then it's less
do that if
likely
you
that your
tried
stents
twice.
may expand. So that's
All
one
right.
I'm joking. You'll
shockwave I
never do
think
that if you
maybe
try even twice.
of an added value.
All right.
Very true.
All right.
So you can see what happened there, and I think that's good for the audience at home. You know, Raman is just pushing the wire carefully. The wire popped into the renal, so you can imagine if you're doing a glide wire or a stiff shift, you could actually perforate the renal very easily.
Yeah.
So always
Always
use
on
safer wires. And so now again, this is where your contralateral access helps. Listen, we're still not out of the woods in terms of whether we're going to stent the contralateral side or not. I think what I think what all of us here are thinking is that let's balloon this. Let's see if there's any plaque shift, how the contralateral side looks, and then decide. Because one of the things is you can do kissing VBXs or kissing live streams, whatever your standard choice is in this situation. But I think that you'd like to upgrade the sheets and have things ready as you go. And the question is how far deep do you hang it out in the aorta? Send me that just so we can see it. Yeah, how far do you deep do you hang this in the aorta, and then we decide, right? So here's the picture again. For everybody to know, see we're eccentric in the aorta. You can see that. So now we're going to go up with the balloon. So question is, I agree with Ajit. I would have probably gone with a 5 here or a 6, not a 7, because I think we don't know exactly where we are. But I think here we're going to just create a track. And then we have the balloon to tamponade out if we need it. Damien's got the equipment ready if we need it. And again, our fellow Usman is going to go up slowly, not rapidly. And I think that's important for interventional cardiology to understand. Go up slow, make a channel, watch the heart rate, watch the blood pressure in these kind of lesions, because things can change in a hurry if you rupture something quickly. The other thing I often look at is the expansion with the wire in relation with the balloon. So you can see here that there's differential expansion of the balloon on the lateral in the external iliac, which means that you're likely more subintimal in that area, which again would probably go towards you going with a covered stent rather than the self-expanding stent. You can see where we enter the aorta, we're more central luminal. So therefore, I think I agree with Ajit. We probably did enter in the right area, but we don't know. But you can see there is a difference in the expansion, and the best way to look at it is in the AP view. And if you want to go to a different view, just go to a different view, and it'll show you even more. So now Raman's going to walk this back. We're going to watch our pressure.
I think we have to hit
to the proximal, and then we're going to go up one more time, and then we'll take a shot from above. And also look at the bladder, guys.
What was this?
Perfect. That's what we
Now come
want.
back to the mid of the femoral head. So
Also look at the bladder. Obviously the bladder shift, things like that are little subtle signs that there may be something happening that you should be more aware of and have it. And it's normal for the pressure to drop a little bit, but again, a significant drop as it's doing right now is concerning. But we will come back a little. We do have everything ready. We can always track this balloon up and occlude the aorta as we need to. So
you can come back more.
Come back a little more, yeah.
Come to the middle of the femoral head.
What do you think, Ajit? A little more, right?
Yeah.
A little more.
It's a 5 balloon. You can come a little bit more, touch more. Oh.
Yeah, maybe a touch more. Yeah. Yep.
Not sure, because we don't want to go too far down here.
Yeah, let's go up. We can always do it again. Let's go up. So we're gonna go up here. So it's 9 o'clock. I'd like to get this done. Like I said, within another 30 minutes. But obviously, patient safety is the most important thing. So right now, we're just gonna balloon angioplasty this section. Again, look at the eccentricity of the balloon. Looks like down below we're more luminal than subintimal, and I think the IVUS also demonstrated that very easily for us. So you can see that the patient is not having any pain, no bradycardia. Our ACT is now 286, or 236, excuse me. And so we may give a little more heparin before doing our Viabon or our VBX or our live stream. Down? A little bit further. And I think, Ajit, it's important to comment on the choice of stents in different areas. Let's just see how we look, and then we can talk about that. Go up there, guys.
Nice. So the stent balloon is expanding very well. So I think
we'll
have a good idea.
So the one thing I want to just go over is when you walk this out, especially in these CTOs of these long iliacs or aortas, if you do them, keep the balloon attached. Don't detach the balloon as you walk it out and you take a picture. Because God forbid you have a rupture, you can shove the balloon quickly up and go up with the balloon and include the rupture and not have to worry about attaching your end deflator. Just a small little tip. Ready? Cindy, guys? So we're going to see now. Pressure is good.
That pressure tracing is
And
incredible.
pressure gradients have also gotten better.
Yeah. Yeah, that's a good indirect indicator, the pressure training itself. Very nice.
Yep. So we have a nice
no
flow
perf,
now.
Looks good. Flow is better.
Yeah.
The waveforms are much better on the hemodynamics, so that's all good signs. So
I'm a little unhappy with where we entered. I think we're a little more eccentric than I wanted to be. So now the question is whether we have to reconstruct the distal ostium or just put a VBX Ajit. What do you think?
yeah.
Bilateral or unilateral?
I think we can try a unilateral VBX.
Okay.
And then choice of stent, like we were saying, we need to nail the, origin. So I think a balloon expandable. I think VBX is a great choice here.
So give us a 7.0. The nice thing about the VBX was Osman. What's the difference between what is nice about the VBX? I mean, just tell us a little bit about the VBX stent.
So balloon expandable covered stent by Gore.
So it comes in two sizes, right? So it's a 7.0 regular and a 7.0 XL and 8.0 XL, right, Mike? If I'm saying it right. 8.0 is XL. Yeah. So the 8.0 XL can go up to 16. The 7.0 can go to 11. Yeah. I don't think we need to go to a 16 here, Ajit. Do you agree?
Yeah,
I think we'll just go with the regular 7.0 and post-dilate it.
What was the IVUS size?
What was the IVUS size? That's right. IVUS size, guys?
It was 11 and 13. Yeah, in two dimensions.
I think we can still just go with the
we can confirm.
Like 8.
You want to go 8XL?
Yeah, we can do an 8 and then.
Mike, you got an 8XL, buddy?
Ajit, do you like to put a balloon in the other iliac?
No.
On your placement?
No, I personally don't do that unless there's a lot of calcium at the origin. I think it's going to crush the other side. But to be honest, I don't typically do that.
Yeah, I think also, Atul, with us having a catheter across it,
correct.
We have good access with wires. I think we will be able to jimmy a stent across it and kiss if we need to. So we're going to get an 8059, right? Or what do you have? 79 or 59?
59, 39, 79.
What do you want? 79?
What was the length of this balloon?
The balloon was 100.
100.
Yes.
79.
79. 8079. I like that.
Yeah, and then you can do a self-expanding.
Well, the idea that's going to be the next point of discussion is how you're going to deal with that circumflex iliac and the common femoral. Raman and I were thinking about putting a what is it called, supera, because you can put a 7.5 supera into it and see what happens. But that's another choice. Or we could just do a regular 10.0, Absolute Pro or any sort of self-expanding stent, or we could put a short vibe on. I don't know, whatever you guys want to do. I mean, we've got all the access here. Everything is ready. So that's the question what we're talking about.
So my preference normally is to use a Vibon in the external iliac artery. I think they do very well there.
Yeah, another 1,000.
The only issue here is that there's a big collateral there. So if these stents go down, you try to obviously preserve all your collaterals in any situation. So using a bare metal may increase that chance. So I think a Superior is a good choice.
Okay. I think,
and also we expanded pretty. Sorry, we expanded pretty well here. So
okay, good.
So I think the Superior is going to be fine. I don't think we're going to rupture or anything like that.
I think I agree with Ajay, especially when we did the IVUS, there was not so much calcification there. So we could get away with the self-expanding bare metal stent. And we can hopefully keep the collaterals open at that time. If there's a lot of calcification, of course, the covered stents are usually the treatment of choice. But in this case, I think we can get away with a bare metal self-expanding stent and keep all the options open as well for future access, for collaterals, and for expansion. It should give us decent results. But.
So I want to just maybe I'm the one throwing salt in the ice cream here. But, one of the things is, when you look at the eccentricity of this, covered stents, and I think Ferry's has said this quite often, Flora, where, they give you a sense of false sense of security, because the eccentricity of that, you can always dissect up that aorta. So you got to really have a seal. So I think it's very important for you to really land it in a spot where you think you're going to have a seal. Let's do a nice DSA. Let me go AP here. We'll do 2 views. So let's do a nice DSA.
I think that's why Ajit had pointed earlier in the conversation saying IVUS will help with the sizing, because if you undersize the covered stent, then you don't get the seal like you rightly said. So very important to get a seal just in case something hits the fan. Yeah,
but that's a great point. To get adequate seal when we do like aneurysms and things like that, we're talking about like 1 to 2 centimeters.
That looks good.
I don't know.
You don't like it?
Maybe go in.
I mean, I want to. That's why we're here. That's why we have a jet, and we're kind of discussing. To me,
So-
I
like it.
I'd like to go a little higher, but I mean,
No.
I'd like a little bit higher, and then maybe put a stent across the other side because we have an aneurysm there as well. We have a landing zone above the neck of the aneurysm to preserve the hypogastric on the opposite side, kissing VBXs, and I think we get the seal at least in the distal aorta, or we could do it. Problem is, if you land it too low, you can't go backwards. That's the
Correct.
point.
Yeah.
You can land it high and go forward, but you can't. If you land it too low, you can't go backwards. So this is the judgment call, and I think this is where multidisciplinary really helps. Ajit obviously does aneurysms, and we're not doing the aneurysms in the cath lab, so he understands this a little bit in a different perspective than we do. So that's my only question, Ajit. Would you take it higher, leave it here, silly? Let's give him another view. It's a little bit angulated view here, guys.
Yeah, so I think if if we're talking about the other side, we can't go much higher without compromising it,
Right.
needing kissing stents. But to your point, if we
More for
rupture right at where it, occludes, then it may not seal where the stent is now.
Exactly. See?
So I guess it just depends how how likely we think it is to rupture. And
I don't think it's highly likely to
I-
rupture.
yeah, I would say it's relatively low because the balloon expanded pretty well. So
Right.
to avoid kissing stents, if we think it's going to make a big difference in this case, I think it's reasonable to try it around here.
Okay.
Yeah, that's what I'm saying. I think I
Yeah,
like
try to
the
flare the
origin.
ostium
It
a
looks
little
good.
bit.
And the ostium on the right is not that much
What-
compromised. So worst case, if you have to do it, you could do a kissing stent, like you said. You
Another
should
what?
be able to pass any stents of
Good.
caliber
Right
on
now
the
it's
right
good.
side.
Is Mikey out there?
Yeah.
But the stent position to me looks good. I mean, unless
Yeah. No, that's a good point. We could still do kissing
How do
stents.
you,
if we
so
wanted to.
we have the expert from our industry colleagues, and obviously they also see a lot of stents a lot. And the beauty of the industry is also it's important for the operators to remember they go to multiple different hospitals, multiple different experts, and especially the ones who are knowledgeable. And you can pick them out; they're very rare, so you can pick the ones that are knowledgeable out. But the point is that you ask those guys and gals what they think. So what do you? I think it looks good. All right, it looks like everybody's a thumbs up here. I think everybody feels like it's confident. So I'm just gonna fix this. Raman's gonna check. Okay, I think we'll go up here, guys. Let's go up slow, like we talked about. Nominal is.
Going up.
So remember, you don't want it to slip up or down. So you want to just hold a little bit of pressure.
Yeah.
And then let it expand slow. Again, Elizabeth and Jen are gonna watch for pain, bradycardia, hypotension.
I like it. It's good.
Right. Let's see. And remember, the beauty is we can flare the prox if we need to.
Yeah.
Right.
It's expanding well, so evenly too. Yeah.
Well, remember, this is another thing. Don't get fooled because you want to look on both sides to see how it expands, right?
10.
True that.
What is it? 12?
10. 10.
What is nominal?
12.
12.
What is
12
12
is
and down?
nominal.
Down. Okay. So, okay, let's go up again slowly to 12. So again, you want to see how she feels as you go up. Good.
Mm-hmm.
12.
12.
Get down. So remember, you can also have rupture at the distal edge. So you got to think about every part of this. You can have proximal rupture, distal rupture, and I think you just got to watch this carefully. So, and again, let the balloon come down and don't infold the stent as you pull the balloon down. So sometimes you might need to mag up and make sure that the balloon is completely down for yourself. There you go. You just want to make sure that you don't infold it with the balloon. So just be very careful as you pull it out. Because I've actually inflated one of these stents, and it's a pain in the neck. See, there you go. See how
So I think one of the strategies which we've been taught in
Keep it there.
interventional, like Raman will tell you, is first actually to push the balloon more in, and then you took it out. So that way you really don't infold it or catch on the center. See? Perfect.
Pretty
Even a little
good.
twist and rotation sometimes
Beautiful.
helps. That looks
Yeah.
gorgeous.
Yeah, it is gorgeous. But remember, you never high five until the case is done, right? So
Oh, my
we're
Lord.
still not done. Let's walk this out. And now let's decide how it feels on this side. Now the question is, what are we going to do here?
My vote will be for the self-expanding bare metal stent, but that's my vote.
Yes, sir.
That's my vote also.
Yeah, we definitely need to stent it. It's self-expanding. Yeah. We
All
could
things
get away
considered,
with
that branch we were
Collapse.
talking
Correct.
about is kind of already on the way out.
Yeah.
I don't know.
So, even ever since that first initial 5 balloon inflation, that the vessel was already starting to slowly fill. So my fear is
Correct.
even with the balloon expand, even with the bare metal, it's still going to close anyway.
Right, exactly.
Yeah, but I mean now that is out of the
Yeah.
picture. So I mean,
Yeah, that's a good point. It also might just be a little competitive flow too. now
Correct.
That
Yeah,
the
exactly.
Iliac's open. But I think there is a good chance that it may get disrupted with any sort of stent.
Yeah.
True.
But I still think, what do you think? Bare metal, or you?
I'm just, we were subintimal to that point. I mean, I just think, what are the disadvantages of the Viabon? We put a short Viabon and maybe a short 10-0 bare metal, and I don't know. I mean, I know it's more cost, but I just don't like that subintimal side of where we are in that external iliac. And I think we were quite subintimal. If you look at play the IVUS again, and you'll see it. Play the IVUS from the beginning.
So PK, your biggest concern is that the self-expanding would not expand or it won't give you true luminal gain because we're so subintimal?
No, the problem I have is, when and this has happened, and again, after a lot of cases that we've done here, we've had one, everybody has their one crazy case. And, you always remember and try to learn from things that happen to you. And, when you're this subintimal or subadventitial, as Jim McKinsey would say, is that what would happen is, the self-expanding stent, if you put a 10-0, will continue to push outward. And you have no strength on the wall. And the one that we had was the patient, unfortunately, had a rupture, delayed rupture because of erosion of the stent through this space. I know it's very rare. We all do it. But I think this type of lesion, when we're really, really so subadventitial, I think it becomes, I'm concerned about it. I don't necessarily will say that we have to do it, but I want to bring it up a discussion point because I think that, you've done such a good job. You've covered up top. And now the question is, do you put a shorter Viabon in and then if you want, deal with the distal, anastomosis or whatever, the re-entry point with a DCB. You see how, look at that right there. I mean, look at how much in the adventitial space you are. Yeah.
No, you're right. I mean, listen, it's better to be safe. In this case, it won't be wrong to put a short Viabon in and seal it off with the subintimal space, and then more.
The only question what Ajit said though is the same thing. Like, let's just do a low mag shot of the foot of the SFA, because I think that's also important for us to understand what is the flow of the profunda and what is the lifeline of this foot. Because I think that's going to be another influential factor for us. How do we rotate this? Oh, no, I'm sorry. How do we rotate this thing?
You want to go?
Yeah, long. Oh, that's long view. Good. Let's low mag now. Yep. So I just want to show the SFA here a little bit. Okay. All right, good. Let me just come back a little bit. Okay, ready? DSA. Maybe it's mental, you know what, but...
No, I mean, the other thing you can do is get all the discrepancy out by, you can just repeat an IVUS. I mean, if you're really concerned, the IVUS should hopefully give you some idea of how subintimal or subadventitial you are, if you think that's what the real concern is.
Yeah.
So I think maybe the best of both worlds is doing a short Viabon and then either a DCB or Secura, because that way we mitigate the risk of rupture, and then we also can potentially preserve that collateral.
Wow.
There's your SFA. Okay, so I mean, the profunda is kind of the lifeline there, but so now the question becomes is, what do you want to do? So Mike, do you have a 8057 Viabon?
So you're going to cover that collateral
or shorter?
Down? You're okay with that?
I don't think you have shorter.
There's a 39 here.
Yeah, it should be a 39.
Yeah, we have 59.
Viabon.
Oh, Viabon.
Don't you think Viabon or VBX?
Viabon.
Viabon.
Because we're going pretty low.
Yeah.
8. You have a.
Yeah, we'll switch it.
850.
No, short. 39? No.
So I don't think yes. I think 57 is the shortest. Remember, you also want to have a seal within the VBX. So that's also important. It's not wrong in putting a 9.0, but I think an 8.0 is reasonable, and then get a seal within a VBX. So 50, that's okay. All right, give me a 0 and 8 wire now. So anybody from home making comments on this? Anybody screaming at me saying, "Why are you doing this, PK?"
No, I mean, listen. People are talking about, again, self-expanding, balloon expanding, covered, non-covered. I mean, proximally everybody agrees to your strategy of using a VBX because that's the right thing to do. And of course, trying to save the ostium on the right side, which we were successful enough to do it in this case.
No, we'll do it in a
Some people do comment, like one of the comments was, which actually was in echo with what Ajit said, what about just doing in the CFA? They're concerned about centing, so they want to do just a DCB, which I think is not a bad option. We can put a covered stent there and do the DCB of the rest of the segment, so that future access remains there, even though we could do it through the stent as well, but just for future access. So that's one of the good viable options and suggestions which Ajit had already said on the screen. but again, there is mixed. Some are like, okay, just do a self-expanding stent and get away with it. But your point is well taken, PK, regarding the stent migration and the complication and the degree of subintimal space you are in. Should always be considered.
You know, she's a claudicant. You know, let's put everything in perspective here.
Right.
She's a claudicant, yes, and you don't want to lose the collateral, but I mean, like I said, things happen, and you know, the problem is, you know, the outward chronic outward force of these self-expanding stents, you know, have to be considered because it is a chronic outward force that you're having here in an external iliac that's extremely diseased. Yeah. So, you know, to me, I mean, listen, I don't think you lose anything by doing this. I mean, it's a Viabon, it's a durable stent, it's a well-studied stent in this space, and we know how to deal with it. My only question with the DCB is the outflow. You know, if I have a dissection, if I have a bad-looking outflow with covered stents coming across this, am I going to thrombose these? So, we know we have some very, very weak data. No, I wouldn't say weak. I would say we have data with common femoral stenting, but it's not necessarily ideal. So one of the things I may do here is just go ahead and do this, and then do a DCB, and then send up for a JIT for an endarterectomy in a month or so that the endarterectomy and we ensure our outflow. I don't know if a JIT would be difficult to operate on this after stenting or proximally, or how does that affect
actually,
you?
That's a great point. I think one of the considerations is where I'm going to clamp proximal. So the kind of stent that's used there. So if we used a VBX and I clamped there, it wouldn't re-expand,
right?
And I would crush the stent. So another advantage of using a Viabon is if I clamp it, it's a self-expanding stent, so it's going to reopen after I release the clamp.
Yeah,
so,
and I think
it's doable.
But that's also something you have to think about. You know, what's more durable than an endarterectomy in today's day and age? Not much. I mean, morbidity is very low. You know, the plus he may be able to tunnel an SFA for us, for us to actually get into the SFA and then revascularize the SFA if she decides to run a marathon. Who knows, right? So I mean, people at 80 are doing amazing things these days. So I think that you got to keep all options open and also understand the multidisciplinary nature.
Yeah.
So we're now going to go ahead. We're going to do a Viabon, and I'm just going to look at, can you call into room 4, see what's going on?
So the other thing is, are we still going to post-dilate that proximal?
That's what I was going to ask you. I think so, right?
You have to,
I think so.
Yeah,
it's up to you. It was 11 or 10, I mean.
So the only caveat is it may foreshorten the stent a little bit. So maybe not being very aggressive about it, since it looks pretty good already.
Right.
Because you don't want to foreshorten it and then potentially lose a seal if we did have one.
That's a good point. And also we have almost no gradient right now.
Yeah.
Right, Flora?
So I think you can make the argument either way, truthfully.
So I'm just going to take this up. We need to get see, it's so eccentric, Vishal.
Yeah.
You see that? It's so eccentric. I would actually go further in, huh?
Yeah.
Yeah, I would.
I agree with you. I think the eccentricity really puts you off, and there's no downside to using a covered stent right there, except for losing the collateral. But in this case, you're right.
No, we're going to be higher. We're going to be higher, as you can see. And then if I can do an endarterectomy, if I can do an endarterectomy with the JIT in a couple of a month or so, I think we're good.
Well, that's perfect. Actually,
yeah, I think that's good.
I think that's good.
Yeah.
And then we can, if we have to, we can just do a DCB, 7/0 DCB right there, and just.
We are going to do. There's no question we're going to do a DCB, but I'm just saying that at this stage, I don't think I want to stent the common femoral because I think we have other options for this young lady.
Correct.
Right, and this is still the iliac, so I couldn't doing an endarterectomy here would be very, very high. So.
Okay, get us a 7015 Viatrac, guys. So I'm just going to balloon this junction and this thing with an 014 renal balloon, 15 millimeter balloon. And then we're just going to go ahead and then deal with the ostium and then DCB this.
Yeah.
So beautiful. That's all I need.
But in this case, I definitely would not leave without a good endpoint because this would be like a reason for the stents to go down.
So we need. I mean, we need to be aggressive. Even if you need to do the endarterectomy tomorrow, you do it tomorrow. In house. Whatever do, leave her on heparin for tonight or whatever, and then do it tomorrow. So I think that's, it's easy to default to stenting, and I just want to discuss this. I know the surgeons who are kind enough to follow us obviously have the skills to do endarterectomy for interventional cardiology and radiology. I think you need to think about what are the other options to really increase the durability of this. You have a great stent result. If you stent the common femoral, and if you have, this is 014 or 018?
This is a 018.
018. Okay, guys, give us an 018 what is it called? A barred balloon, BD balloon from there. Short,
No,
7 millimeter or 8 millimeter.
You have a fielder. Just change the wire.
No, not fielder.
No, you don't want to do it. He's got an 018. What short do you have? 7.0 or 8.0? You have 6, no 7 or 8s? That's fine. Give me that. 708 is fine. So we have an O&A balloon. We're just going to go with the BD balloon here and just balloon it open. And then, like Ajit said, we'll take a good effect. The other thing also, remember, it's physiology. Our sheath, our 8 French short sheath is distal to the lesion, and there's no gradient. Yeah. The gradient is literally 6 millimeters. So obviously the flow is good. The outflow is good. But again, I think it's important to IVUS that distal aspect. Have an 018 IVUS ready, guys, after we balloon this. I need a 9.0 short 20 millimeter balloon up top, or 40. Where would you go with the Jit up top?
40. What were the choices?
And I was thinking 9.0, but whatever.
Yeah, 24. I think definitely 9 for diameter is sufficient since it already looks pretty well opposed,
right,
and appropriately sized.
You think 20, 30, 40?
Yeah, 20 or 30.
Yeah, 20 or 30 is fine. If we don't have 30, we'll take 40. 9.0.
Because you don't want to use a longer balloon and foreshorten, a lot of the stent.
Sure.
Although the VBX does pretty good about not foreshortening that much.
Yeah, I think VBF is a phenomenal stent. I mean, it's as is Livestream, but I think VBX has some advantages. It's more deliverable, flexible, at least in our hands. And I think also VBX, the ability to tailor it to different sizes is beyond what Livestream is able to do.
What's nominal on this?
Nominal balloon?
8. I'm assuming no pain. The patient is feeling
She's
fine.
having pain.
Oh, okay. Well, a little bit of expansion. I think that should be good enough.
Good.
Beautiful. Down. All right, good. So again, about the crossing, guys, sometimes that's why the reattempt helps. See, what happens is you create dissection planes earlier, as long as you're not super aggressive and go into the aorta or anything like that. And then you come back, and then these dissection planes actually, recanalize, they get blood in them. And then all of a sudden now you have, an easier way of getting through. I can tell you, Osman and I, we tried that same sort of area last time. So there's your competitive flow. So now we're going to do an IVUS to look at actually, we're going to balloon the top first, right? Let's do balloon the top and then do an IVUS first. Yeah, and then we'll be done in 5 minutes with the IVUS, and then we'll close up.
The distal endpoint looks a lot better.
Yeah, right. The distal endpoint looks a lot better once you tacked it up. Sorry.
So. Yeah. It looks great.
And the gradient is essentially gone.
Yeah, you're right. I mean, it's just it's pretty much taken care of. There's a good flow, outflow, and proximity looks beautiful as well.
Floor here. Mm-hmm. So, Ajit, would you hang this into the aorta a little bit or no?
Yeah.
A tiny bit.
I mean, I would probably leave it right there a little bit.
Yeah, I think that's perfect.
Yep, just a little bit and just go up slowly.
Yeah.
Yeah, you think you're right.
It also depends on the waist of the balloon too.
Yeah.
Like how much of a waist it will have.
I think it has a little bit of shoulder as well, so I think that point looks great. And you're right, using a smaller will probably cause less shortening because we're just trying to expand just the proximal most end of the stent. They were not changing the geometry of the remaining part of the stent. So I think that's a great idea.
That's 6 atmospheres. Okay, good. So now we can always change out for an 035 wire if she has pain or rupture, which thank God she doesn't. And now what we're going to do is do a quick overnight IVUS, and we're going to let you know what we're going to do and call it a day. Quick DSA guys here.
Looks beautiful.
I think we're done, huh?
Yep.
That looks pretty.
Yeah.
All right, so now we're going to just put the IVUS in, and then we'll be done in a sec. We're just the IVUS really is for both, obviously above and below. But I think what we're concerned about is the common femoral. And I think for me personally, if the flow is good, and the angiogram looks bad, I'm going to send her for endarterectomy on Friday here, and then be done with it. I think that may be the way to do it.
Yep.
I think that's a great option. I mean, having a hybrid approach where you're trying to have the least morbidity and good patency results, I think this is a perfect approach. Getting your iliacs treated this way, and of course, endarterectomy, we already know the results are excellent. So that would suffice her at least have a significant improvement in her claudication symptoms.
So record, guys.
All right, so that's what.
So that's distal, and Raman G is going to pull back here, coming into the stent. Okay, right, well expanded. Good. Now you're looking for infolding, and that's in the key. And you know the stent may be elliptical and all these other different ways, but clearly, and you want to look at the junction of the Viabond VBX to make sure there's no endo leak. I think that's important too. I mean, you can do it on chromo, but generally speaking, if it's well sealed, you'll see it.
I think it looks good.
You'll see there.
This is the overlap.
Right there.
There's the overlap. Yep, there's overlap. And now you have two layers of stents, but both 8s, which we didn't touch. And you see how it's compressed. It's different. It doesn't look as see right there's a little bit of infolding. See, look at that. Look at that, guys. Look at that. See, that's where that's worrisome.
That's the distal end. Yeah.
So that's important that your outflow. Look at that. Yeah,
right there. But that's probably landed in the lesion as well. So that's why there's a little bit of infolding right there. There's still some disease just distal to the distal edge of that wire bond.
All right, let's play that IVUS so Ajit can look at it. We can have a discussion on it. Go ahead, Ajit. Why don't you describe it?
Yeah, so I think proximal going from the aorta to the VBX, it looks great. As we're discussing so this is still VBX, which looks well expanded. But once we get to the external, it's a little more compressed. So I think using the Viabond was the right choice for that. And then the question is about the endpoint. I agree with you, Vishal, I did see a little bit of dissection at the end. So the other thing you can do on the IVUS is just measure, how narrowed it actually is to see if it's over 50%, under 50%.
So for the people at home, I mean, with vascular-wise, 50% by IVUS ruminal reduction equals 70%, right? So it's a right. That's a little worrisome to me right there.
Yeah, I agree with
you.
PK is right in that. Probably needs a little bit of more.
See how like elliptical that lumen is? It's not a great lumen. Look, and then now you're in the true vessel. So one of the things Ajit could do is like we could just do a quick DCB here, and then what he can do is when you're back in the OR, you just put a balloon expandable or another stent inside that stent. I mean, it's up to you. What do you think? I mean, would you treat that?
I think DCB and close surveillance is a good option.
Okay, let's do that first. Okay.
Yeah, and then if there's any recurrent disease or if it's still suboptimal, then I could just do an endarterectomy up to the, Viabond, and then that'll fix everything.
All right, so then let's give us a measurement on that common femoral. And then I'm gonna close this, Ajit, and Raman, as well as Vishal and Atul, by just saying that, we're gonna DCB this common femoral. I don't think anything is really gonna happen. I don't think we need to be on live to see that. Right. I think it was a great case. Osman, great job in terms of your presentation. Raman, thank you. Ajit, thank you for all the comments. And I think what we'll do is we'll see you guys live at our symposium and our summit coming up in about a week's time. Next Thursday, we'll be there. So hopefully we'll see all of you live or virtual. And thank you again for joining in for this great case. Thank you.
Awesome.
Thank you.
Okay. All right. Sign off.
Yeah. Thank you so much, everyone, all the viewers, for joining us here for our monthly live broadcast. I hope you enjoyed this lively, interactive, and very exciting case with good treatment strategy, thought process plans, and the steps taken for a successful intervention. Just again, just reiterating PK's point, we'll love to see you next week in person, live, or online for our New York Endovascular Summit. Please go on our website, nyebs.org, register, and have a exciting Friday and a Saturday for our annual peripheral vascular disease endovascular symposium. Thank you so much for joining again. We'll see you next month, October 26th, 8 o'clock Eastern Standard Time here from Mount Sinai Hospital. Till then, have a great week and a month ahead.